Hello, good morning, good afternoon, everyone. So thank you for joining this session where we will be discussing more about antimicrobial resistance and the current challenges in humanitarian settings. Today, we have a fantastic panel, but just to set a bit the scene, we know that antimicrobial resistance represents today a global public health challenge. Today, as many as more than 5 million people possibly will die in low and middle income countries each year because they do not have access to the right antibiotics and diagnostic tools they need. The international community has manifested its commitment to develop and implement effective policy responses to fight antimicrobial resistance. But despite the global discourse, collective action has not taken over, and several countries are still facing many challenges, specifically in humanitarian settings where we have still many blind spots, countries who do not know about the burden, countries who cannot effectively diagnose patients or treat them, but also specific situations as the ones faced by conflict settings, where the lack of access to care gets more complicated due to the medical problems that patients face, such as war-wound injuries and others. MSF has recognized the relevance of antimicrobial resistance. This is why, since 2015, we took this as a priority. There was a setup of an international task force, and today our projects have been implementing several pilots around the world. MSF has witnessed the disproportionate impact of the antimicrobial resistance in some of the most vulnerable populations around the world. And this has been, of course, worsened by the pandemic, which has magnified pre-existent health inequities and had a major impact in the places where we work. So today I have the pleasure to introduce a great panel to discuss the topic. We will start with a presentation by Mr. Anand Balachandran from WHO, who will tell us more about the global situation of antimicrobial resistance and the challenges and the plans. Then we will have a presentation by Dr. Hossam Altamas from MSF, who will tell us more about the experience and the projects in Gaza. Then we will have the pleasure to have Dr. Hiroshi Yotsuyanagi, who will tell us more about the Japanese situation and will tell us more about the policy and AMR strategies in Japan. And then we will have Dr. Hossam M, who will tell us more about the importance on research and development and the current situation and the plans and the challenges we face in terms of research and development. So now I will continue by introducing, I have the pleasure to introduce Dr. Anand from WHO, who will tell us more about the global situation and AMR. Dr. Anand has vast experience working with infectious diseases. He has been working with the WHO for a long time now. And today he's leading the AMR team and WHO, and he will tell us more on what is the situation around the globe. So please, Dr. Anand, the floor is yours.
Thank you. Thank you, Angela. Thanks for this opportunity. I'm very happy to present to the group. Apologies, I'm just getting out of another webinar. Can you see my screen?
Yes, we can see your screen.
Okay, great. So I'm going to provide a short update on countries that are implementing national action plans to address AMR and some of the critical challenges that they are facing, and also what has been WHO's response to these challenges. A lot of the data from in this presentation comes from an annual survey that is conducted where countries are requested to fill out information on how they are addressing AMR. So many of my slides will show data from 2021 when the last survey was conducted, but also show some progress over the last 5 years or lack of progress. So just to give you a sense that the data being collected is from a scale of A to E, A meaning zero progress, and E meaning the most capacity to implement their plans. So let's start. So I would like to start off by highlighting this figure that clearly shows from a recent survey or recent study from the Lancet that antimicrobial resistant infections are associated with close to 5 million annual deaths. So finally, we get a sense of the burden of AMR. And we need to respond to this. And countries need to respond to this. The global community needs to respond to this as a pandemic. It is silent, it is considered silent, but for the patients who are suffering the impact of these resistant infections, it is a very, very real problem. So, how are countries implementing and developing their national action plans? So WHO has 194 countries or member states, and about 163 of them participated in the last survey. The graph on the left shows that more and more countries are towards what I would say level C, D, or E, which means they have a national action plan. They are beginning to implement their national action plan. And the graph on the right shows the progress over the years from 2017 onwards. You see the green bars becoming bigger and bigger, showing that more countries are now truly engaged in establishing national action plans. What is concerning is that the level E you see on the graph on the left shows that only 32 countries are monitoring how they're doing. So we are at a situation where we know the burden of the problem from estimates, but countries need to do a much better job of tracking what they're doing and collecting data and sharing data so that we use the evidence for decision-making and policy-making. Countries need to be applauded that in just 5 years, 163 countries and maybe more have now established national action plans. It's interesting that national action plans to address AMR not only deal with human health, but we are happy to see that animal health is also very deeply engaged because this has a big impact on animal health as well. And misuse in animal health and human health is a major problem. Misuse of antibiotics is a major problem that needs to be addressed. What is, however, not well shown in this graph, and it shows a lack of progress, is the agriculture community, plant health, food production, and the environment are still not fully engaged in the implementation of national action plans. This is a problem because unless all of us work together, this problem cannot be fully addressed. So we need their engagement, food production, agriculture, and environment. Given that AMR is a multi-sectoral problem, we asked a question whether countries have established groups where we can work across ministries, health ministry working with the agricultural ministry, working with the animal health ministry, environment, water. And this figure clearly shows that there is a big problem. These groups have been created, but they're really not functional. The majority of the response is in level B or C, and only in mainly high-income countries there is a lot of engagement. But in the majority of low and middle-income countries, these groups have been established, but they are not very functional. This is very problematic because donors, external partners wanting to go to a country to see what is happening are even unable to find out who is in charge of AMR in the country. Everyone keeps talking about One Health, There is no One Health ministry in countries. You need to bring all these sectors together to work together. So this is a big challenge that needs to be addressed. Another big challenge, and this is really surprising for me at WHO and for other colleagues, is that despite all the messaging on AMR in the past few years, we can see that in the vast majority of countries, only very limited small-scale awareness campaigns are being conducted. And that you could see in the graph, 47% are at level C, which are small-scale, awareness campaigns, and they're not even targeting all the stakeholders. So there is a big opportunity for civil society, community organizations, youth groups to really get engaged in raising awareness on AMR, and also the professional and medical associations, animal health organizations. We all need to do a much better job of raising awareness on AMR. This is why it is being silent. There is not enough awareness campaigns. The other issue that I would like to point out is even training for professional healthcare workers or animal health, agricultural workers, etc. That once again, training is very sporadic. They are providing some training before people join, or even in their careers, they're providing small-scale training. But what is needed is that AMR as a module is included in the educational curriculum for healthcare workers or field farm schools for animal health, veterinary sciences, etc. We also strongly feel that this is the opportunity to get youth and secondary school students more engaged. Just like in climate change, they are a big force of bringing about change in the future. And AMR is a generational problem. It's going to be with us for 30 years or more. We need the youth to be engaged, and it would be really fantastic if the ministries of education play a role in including AMR as a module in the educational curriculum. With regards to surveillance, this has shown very good progress over the years because a lot of funding has been focused on establishing surveillance of resistant pathogens. So this is good news. We have, I think, in GLASS about 120 countries now providing data. However, there is a problem where this data is not very representative. Just because we are collecting data in a few sites in a country, it does not give us the full picture of what is the big burden, what is the real burden of AMR in countries. So we need to address this. Countries are collecting routine data, but we need to understand that this is limited data. And even this limited data is not being used for decision-making and policy-making. So this is one challenge with surveillance. This is another area where some progress has been made, but it is sort of stagnated. And this is the very big issue of trying to come up with a system to monitor how many tons of antibiotics are being consumed, not only for human health, but for animal health, but for agriculture. This is closely related to trade. So we need to engage with the Ministry of Trade to get this data. How much of antibiotics are being imported? How much is being exported? And at the healthcare facility level, how is it being used? We need to track this information. Otherwise, there is really no system. You can have regulations saying that without prescription, no antibiotics, but without a system, you cannot really monitor it. Same thing with infection prevention and control. With the pandemic, COVID pandemic, we saw preventing infections is one of the biggest things we could do. Same for AMR. This is the most important intervention we could do. But in the vast majority of the countries, there has been no progress over the past 4 years. And there have been small national policies developed, but these minimum requirements are not being rolled out to the facilities where the real work is done at the primary care, secondary and tertiary hospitals. And this is where we need more infection prevention and control. In terms of regulations for optimizing the use of antimicrobials, again, there has been some progress, but it has become stagnant. It shows that more work needs to be done. There needs to be more resources in countries, particularly low and middle income countries, to focus on not only coming up with the treatment guidelines, but then how to monitor those treatment guidelines for addressing infections. So there are many challenges, and I think these slides will be used, can be shared, including the critical issue of equity and access, because there is an issue of overconsumption of antibiotics, but there's also an issue where in many countries, people cannot afford to buy the right antibiotics. And there are many vulnerable populations that cannot afford diagnostics to say, whether they are resistant pathogens or not. We are doing a number of things to help countries implement national action plans. This is one of the responses we have developed. We have also developed responses how to generate more useful surveillance data, particularly through conducting national surveys like the TB surveys and doing more work in terms of lab strengthening and diagnostics. We are developing, and I would really like more feedback on this we will launch a consultation on a new people-centered approach so that AMR is not seen as a silo focused on surveillance and the disease or the bacteria or the antibiotic, but it is seen as an issue of health systems. We have broken health systems, and this needs to be fixed so that people have access to quality care and quality diagnosis and quality treatment. So WHO is launching this framework, and we would need more inputs from everyone. And this is prevention, access to essential services, diagnosis, and treatment. We are also launching a global research agenda because there is no such research agenda on AMR that is led by WHO that provides a global framework, and it's focused on collecting evidence from low and middle income countries. So we are also launching this global research agenda. Lastly, given the recent Lancet survey that 6 resistant bacterial pathogens contribute to 72% of the infections, we need to come up with a new global strategy focused on drug-resistant bacterial infections, and we will be launching this process, and we would invite member countries, and including Japan, to help us raise this in the WHO and WHA forum so that we could develop this new strategy. I will thank you very much for your attention. Sorry for running over by 2 minutes. Thank you very much. Over to you. Back to you, Angela.
Thank you so much, Mr. Anand. I think that set the scene perfectly for our next presenter, because many of the issues you mentioned, I think, will resonate on what we see actually in the field, what we see in the project. And as we mentioned, the lack of access to antibiotics and diagnostics is something that affects the most vulnerable ones. And this is, of course, something we see in conflict areas. As the next presenter, we will have Dr. Hossam Altamas, who will tell us from Gaza more on his experience. Dr. Hossam is part of MSF. He started working as the medical officer in Gaza, and also he works as the antimicrobial stewardship doctor in the project. So we want to hear, doctor, from your experience. Please, the floor is yours. I think you're mute, Dr. Hossam. Can you unmute? Yeah.
Hello?
Voilà. Yes, we can hear you. Please proceed.
Hello, everyone. I will talk about our experience in Gaza with antimicrobial resistance. First of all, I will talk about the geography of Gaza. Gaza Strip is a narrow coastal strip, like you see in the map. It's along the Mediterranean Sea. It's between Egypt and Israel. It is 365 square kilometers. That is slightly smaller than Takamatsu city in Japan. The population number in Gaza, it's more than 2 million people. These numbers reflect the humanitarian context in Gaza. 45% of people in Gaza living under poverty line, over 1 million people suffering from insufficient access to water, sanitation, and hygiene services, and 1.4 million people are food insecure. The unemployment rate reached 49% of people, and the population density is over 5,000 people in the square kilometers, which is one of the most densely populated area in the world. And there is a prolonged electricity blackouts, reach about 12 hours a day. There's a huge shortage in the essential medicines. About 43% of essential medicine of Gaza Central Drug Store are completely out of stock, and 28,000 existing house units across Gaza do not meet minimum requirements of living space per person, weather protection, hygiene facilities, and privacy. Adding to that, since 2007, Israel declared the Gaza Strip under Hamas a hostile entity and approved a series of sanctions that include power cuts, heavily restricted imports, and border closures. And also Gaza faced 4 wars during the last 14 years. These wars costed Gaza, according to estimates, over $5.7 billion, and there was over 4,000 lives lost and 245,000 homes were damaged. This picture from Gaza Strip, it's actually the MSF clinic in Gaza. It was damaged during the war last year in 2021. This wall that is damaged were the wall for the sterilization room in the clinic. Now I will talk about the Great March of Return. The Great March of Return is a weekly demonstration which began in Gaza Strip in March the 30th in 2018 until the end of 2019. Thousands of Palestinians gathered near the Israeli-installed Gaza border fence to call for end of Israeli blockade and return of the refugees. During these demonstrations, 214 people were killed and at least 36,000 people were injured. Most of the injuries were gunshot injuries in the lower limbs, resulted in serious and complex wounds that need months, if not years, of management. And a lot of them are still under management until now in our facilities. This picture from from one of our outpatient clinics in Gaza shows the injured people waiting to receive their treatment. Many of those people developed bone infections because of many reasons. First, the nature of the injury. The dirty foreign bodies penetrating the skin, causing huge wounds, broken bones, and vascular and neurological injuries. Second, the shortage of treatment in Gaza and the big number of casualties led to improper treatment of the cases in the first place. Many of these injuries stayed for days with exposed bones. This is another picture from the clinic in Gaza, shows the injured people. You can see that most of them are young people and have injuries in the lower limbs. Complicating this is what appears to be very high rates of antibiotic-resistant infection. This often happens because antibiotics have been overused whether in the community or in the environment. Patients in Gaza are buying antibiotics without any prescription from the doctors, and the doctors prescribing antibiotics when they are not needed or using the wrong type of antibiotics when they are needed. Treating these infections would be tough anywhere in the world, but in Gaza it is tougher. The healthcare system in Gaza is reeling from the effects of more than a decade of Israeli blockade, Palestinian political infighting, and Egyptian restrictions over movement. So MSF here in Gaza working to provide care that otherwise unavailable. So what MSF did in Gaza to respond to this huge amount of numbers and the bacterial resistance that appeared in these injured people. First of all, MSF increased the number of outpatient clinics from 3 to 5. And in February, MSF opened a specialized inpatient department to treat cases of osteomyelitis. And after that, MSF opened the first laboratory able to analyze bone samples in Gaza. Previously, the samples had to be sent to Israel for testing because absence of labs in Gaza. This map shows where the MSF works in Gaza. It's distributed all over the Gaza Strip from the north to the south area. There's 4 outpatient clinics and 2 operation theaters and 1 inpatient department here in Khan Younis. This is another picture from Gaza Clinic, the MSF Gaza Clinic. Here's one of the dressing sessions that provided by MSF in the outpatient clinic. This boy is 13 years old, and sadly he lost his leg during the demonstrations and due to the injury. This is one of the pain management sessions. It's provided by anesthetist and a nurse. They are doing injection of analgesia directly around the nerve to relieve the great pain that this injuries cause. For the management of osteomyelitis, the MSF work was multidisciplinary. It included surgical debridement, which was very hard and very difficult because most of injuries were not treated properly in the first place. There was delayed and suboptimal initial debridement of the injury. So the surgical team collect the bone samples in the operation theater and send these samples for the microbiological investigations. In the microbiological investigations, they do cultures for those samples to see which antibiotic can affect this bacteria and which antibiotic will be resistant. After that, there was an antibiotic stewardship doctor. He is responsible in interpretation of these samples, and he is responsible on choosing the antibiotic that can affect the bacteria, and he follow and supervise the treatment by antibiotic. All of these interventions are guided with the infection prevention and control measures. This picture from the operation theater in one of the MSF facilities. They are operates on injured person who had injury in the leg. This picture from the laboratory that the MSF started, it was the first laboratory to do bone samples and to do bacterial cultures for those injured people. The results of the laboratory was actually surprising. There is a huge number of multi-drug resistant organisms. Multi-drug resistant organisms are bacteria that resist treatment with more than one antibiotic. during the period between 2019 and 2021, a total 408 patients were with gunshot injuries were sampled. Of those patients, 336 people were positive with bacterial osteomyelitis. What is more surprising that 185 samples were positive with multi-drug resistant organism, which is a huge number. It represents 55% of the positive samples. Also, 19 samples were positive with more than one multi-drug resistant organism. This chart shows the total number of patients who were sampled and the number of positive samples and number of multi-drug resistant organisms during the period of 2019 until 2021. The organisms that was most prevalent is MRSA. MRSA is the most common multi-drug resistant organism and formed 56% of the multi-drug resistant samples. MRSA is methicillin resistant Staph aureus. After that, there is the ESBL, which extended spectrum beta-lactamase, then the Pseudomonas aeruginosa resistant to carbapenem. This resistant bacteria need stronger and more expensive antibiotic. These antibiotics carry high risk of side effects and need more close follow-up. This is one of the isolation room which in the inpatient department that MSF opened in Gaza. Every room has its own bed, one bed only for one patient, and to prevent the spread of resistant bacteria within the hospital and to protect the other patients have to be isolated in a single room during the treatment. Everyone entering the room must wear protective clothing and clean their hands. This picture shows the protective clothes that the staff and the visitors need to wear before entering the room to protect from contact with patients with multi-drug resistant organism. There is a gown and there is a gloves need to be worn, and before lifting the room, these gowns and gloves need to be disposed inside the room without leaving with them. And the most important, of course, the hand hygiene before and after the contact. So to conclude all that, the improper use of antibiotic increased the antibiotic resistance in bacteria. In Gaza, there's no regulations, antibiotics are available, and there is no supervision over its use, both in human and animal health. So providing patients with information on when and how to use antibiotic is important in leading the behavior that will reduce the misuse. Also, about disposal of the drugs, including antibiotics, Gaza is missing the functional incinerator. So MSF is advocating for other actors to finance that incinerator. Laboratory, of course, it's a key tool to fight against antibiotic resistance, because through these laboratories, we can determine the exact type of bacteria causing the infection, as well as the antibiotic it is resistant to. But setting up a laboratory is not easy in many places, especially in places like Gaza that are affected by violence and are seriously under-resourced. So in many occasions in Gaza, laboratory items can be stuck for clearance for many days, and when it finally arrives, it's expired, because these items are usually have very short shelf life. Of course, the health staff are very important part of the problem because doctors might provide patients with wrong antibiotics, which can be ineffective and lead to resistance developing, and can provide antibiotic when they are not needed at all. So awareness are needed during medical and paramedical studies and during the continuous education. And of course, the infection prevention control measures are vital inside the hospitals to prevent resistant bacteria to spread. MSF focus heavily on three critical infection prevention and control areas, which are the hand hygiene, cleaning and disinfecting surfaces and medical devices, and transmission-based precautions. Thank you all for having me. Now back to you, Angela.
Thank you so much, Dr. Hassan. I think you illustrated very well the challenges faced by healthcare workers working on conflict-affected settings as Gaza, and where MSF is directly witnessing the impact of antimicrobial resistance and providing care to these patients. Now, we will move from Gaza to hear more about the Japanese action on antimicrobial resistance. For that, I will invite Dr. Hiroshi Yotsuyanagi, who will tell us more about the Japanese action to fight antimicrobial resistance. Dr. Hiroshi is a medical doctor. He's a professor on infectious diseases. He's part of the Japanese Society on Internal Medicine and the Infection Prevention Control Society, but he also takes part in the Initiative on Antimicrobial Resistance in Japan, where he represents the Japanese Association for Infectious Disease. So, Dr. Hiroshi, please, the floor is yours.
はい、アンジェラさんご紹介ありがとうございます。今ご紹介いただきました四つ柳と申します。今アナン先生、アルタルマス先生の方からグローバルな状況のご報告がありました。で、それぞれいろいろ考えさせられることが私もございましたけども、私の仕事はじゃあそういったような AMR に対して日本は何をしていけばいいのかというふうな今の取り組みを皆様方にお示しをすることです。で、ここにインダストリー、ガバメント、アカデミアというふうな、いわゆる日本語では産官学、産業界の政界、そして学会というものがどうやって連携をして取り組んでいるのかというお話を、主に3つの部分に話を分けてお話をさせていただきます。日本政府はここに書いてあるような、経済財政運営と改革の基本方針、これは日本ではよく骨太の方針という言い方をしますけども、これを毎年6月に出してきます。で、来月にこの2022年度版が出されるというふうなことになります。で、ここは日本がどういった点に経済的な力点を置くかということなんですけども、ここの中で実は AMR が出てまいります。文字ばかり載せられるようにして申し訳ないですけども、上の1、2、3、4でお示しをしたのは、日本が成長を生み出す4つの原動力として推薦するものとして示しているものです。1番はグリーン社会の実現。2枚は官民を挙げたデジタル化の促進。3番目は日本全体を元気にする活力ある地方づくり。4番目は少子化の克服。子供を産み育てやすい社会の実現ということになります。この4つの中そのものには、AMR のお話は出てこないわけですけども、これを実は実現するためには、今 COVID-19 が非常に大きな問題になってますけども、感染症を克服して、それによって経済が回りやすくなることが特に大事だというふうなことが昨年書かれております。したがって感染症の有事に備えて、例えば医療体制を充実させたり、ワクチンの開発をしたりというふうなことも挙げられているわけです。AMR に関しては、下の小さな字で最初のところに SDG というふうに、disease というふうな言葉が書いてありますけども、その中で私が赤で書いた部分、ヘルスセクターとしては、グローバルヘルス、あるいは UHC、ユニバーサルヘルスカバレッジ、 それから一番最後のところに AMR に対して、日本は取り組んでいく。で、世界で指導的な役割を果たしていくというふうなことが書かれています。AMR に関しては、実は日本でその前回 G7、先進国首脳会議が行われた、伊勢志摩サミットにおいて AMR の代表、重要さということが非常に大きく取り上げられました。来年、日本ではまたサミットが行われますけども、そのサミットの時に、やはりまた AMR というものがいかに大事であるかというふうなことを先進国に共有をしていただいて、で、それに対して先進国が一丸となって取り組んでいこうというふうなことをやっていこうというふうなこと、これは我々アカデミアの方から政府に対してこういったことを取り組んでくださいというふうなことでお願いをすることになっています。さて、日本の政治、今お話をしたように骨太方針というものによって貫かれているわけですけども、それを実際には紹介をする、あるいはそのための政策立案をする組織がなければいけません。その組織がここに JHPN、Japan Health Policy Now って書いてありますけども、その組織が日本のやっていることを、一般の方に伝えたり、あるいは我々アカデミア、あるいは産業界から日本の国に対してこういったことをしてくださいというふうなことを提言をする場になります。この JHPN の中にはいくつもの組織があるわけですけども、その一つの代表が HGPI、Health and Global Policy Institute というところになります。この中でAMR が大きく取り上げていますので、そのご紹介をさせていただきます。AMR アライアンスジャパンという組織になります。AMR、そういった AMR の組織、HGPI ですけども、これは2004年に設立されて、非営利的な独立した政治のいかなる政党の影響も受けない超党派の民間の医療政策の我々が要するにシンクタンクと言われるような政策の提言機関です。で、この中では2番目に書いてあるように、エビデンスに基づく市民主体の医療政策を実現すべく、中立的なシンクタンクとして市民、当事者を含む幅広い国内のマルチステークホルダーによる議論を喚起し、提言や発信をグローバルに進めていくというふうなことが書かれています。AMR についてご説明をいたします。AMR Alliance in Japan は、これは2018年の11月に成立した AMR 対策をたくさんのステークホルダーで議論をするように独立したプラットフォームです。右の下のところに小さな字で、こういったようなところが加わっているというふうに、アライアンスメンバーが書かれています。この中には、製薬会社、あるいは私たちのような学会、そして例えば子どもと医療なんていうことが書いてありますけども、こういうような非営利組織、いろんなものが入った組織になっていて、こういったメンバー以外にも国内外の様々な団体個人と連携をしております。小さな文字のスライドになって恐縮ですけども、AMR アライアンスジャパンの活動というふうなことで、一番上のところに我々の使命、そして我々の活動内容、そして我々の活動領域ということで書いてあります。下の我々の活動領域というところに大事なところを太字で示してありますけども、そうすると1番のところで適正な抗菌薬使用の推進。そして2番目は先ほどからお話が出ているような、耐性菌のサーベイランスシステムの確立。3番目のところはそういったような耐性菌のスクリーニング検査の確立。4番目のところでは AMR に対する学習支援。5番目のところにはインセンティブモデルですね。そういったもの、リサーチ&ディベロップメントに関するインセンティブモデルを作ろうというふうなこと。6番目は抗菌薬の安定供給。 適正使用というふうなことで、先ほどお話のあったような適正使用ということが入ってまいります。そして最後は国際連携です。こうして見ていただくと、この7つは日本が打ち出している方針でありながら、実は世界の打ち出している、あるいは世界が必要としているものと重なるっていうふうなことが見て取れていると思います。これは2019年7月に活動の基礎となる AMR 対策に向け日本政府が果たすべき役割、これを AMR アライアンスジャパンが政策提言を実はしたものです。いろいろなことがありますけども、日本の政府としてこういったような様々な観点から AMR に取り組んでほしいというふうなことを紹介をしています。実際にはここに書かれているように、これは2019年の7月から2021年の1月までの活動ということになりますけども、かなり実は大きな活動をしてまいりました。ここに書いてあるように、一番上のところに例えば、薬剤耐性対策について日本政府が果たすべき役割というものを、実は当時の大臣に対して提出をしているというふうなことが書かれています。その他、全部この下 AMR について書かれているわけですけども、最終的に一番下のことに書いてあるのは、そういったことをちゃんとやっていく上では、法律の改正も大事であるというふうなことが実は書かれています。これは2021年の3月以降、そして今年の3月に至るまで、たくさんの政策提言を実はしております。今と同じようなことなんですけども、この後出てくる一番上のところ書いてありますけども、抗菌薬市場におけるプル型インセンティブ。これは政府会社に対して抗菌薬を適正なものを作ってくれれば、それに対して例えば収入の保証をしましょうとか、そういうようなことで政府会社が抗菌薬を作る、そういったような気になるというふうな政策を出すことが大事だよというふうなことを実は打ち出しているものです。下のものに関しては、これは SDGs に関するものがまとめというふうなことで提言をしております。というようなことで、2022年度、今年度の私たちの活動で目指すものがここに書いてあります。ビジョンとして何なのかっていうと、薬剤耐性菌による感染症から日本及び海外の市民を守る強力な医療システムの構築ということが最終的なビジョンです。そして2022年度の時点でのゴールとしては、書かれていることは、2023年度の来年日本で行われる G7 サミット首脳会合及び各大臣会合の議題に AMR 対策を盛り込むことというふうなことが実は大きな目標になっています。冒頭にご紹介をした通りです。もう一つ最後に産官学が一緒になって新しい抗菌薬を作っていこうというふうな、そういった試みについてもご紹介をさせていただきます。日本のこうやった製薬、新しい薬を作っていこうという研究費というのは、主にここに AMR、これは日本医療研究開発機構という組織ですけども、そこが研究費を、大型の研究費を出して、活動をしてもらっています。ここに書いてあるのは我々感染症学会のロゴですし、隣のものは日本化学療法学会というもう一つのパートナーの学会のロゴですけども、学会、そして今言ったAMR という組織、これは政府の意向を受けてお金をここから出すということで、官の立場になります。そして GPMA と書いてあるのは、これは日本の製薬会社の製薬協というふうに言いますけども、こんなようなことで産官学が一緒になってこういったような新薬を作っていこうということになります。これはここに WHO と書いてありますし、ここに CDC と書いてあります。こういったところが非常にその開発の優先度が高いということで挙げている微生物の名前です。ここにいろいろなものが並んでいますけれども、先ほどお話が出たようなものも中には含まれているというふうなことになります。こういったことをもとにして、我々の産官学共同としたこの組織では、 ガイドラインを出したり、推奨を出したりというふうなことも実はしております。最近もここに書いてあるような、先ほどご紹介をした HTPI の方から、グローバルポリシーというふうなことで打ち出させていただいています。これが最後のスライドになります。我々の、AMR アライアンスジャパンは決して長い活動をしているわけではないですけども、それでも確実に毎年毎年いくつかのステップを踏んで、世界の AMR に貢献しようということで頑張ってまいりました。これからも世界のステークホルダーの方たち、あるいは各国と共同しつつ AMR を推し進めていければなというふうに思っています。私のお話は以上です。どうもありがとうございました。
Thank you so much, Dr. Hiroshi. I think that illustrated greatly where Japan is today. And I think you touched on very important things such as the intersectorial action and how academia, private sector, and government should come together on the fight against antimicrobial resistance. I think that takes us very nicely to the next presentation by Dr. Hossam M, who will tell us more on the importance of research, development, and the current situation and the plans. Dr. Hossam M is the CEO and Executive Director at the GHIT Fund. He is a medical doctor with vast experience on international organizations such as the Global Fund and UNICEF. His current role has a focus on innovation and global health. So please, Dr. Hiroshi, the floor is yours. Sorry, Dr. Hossam.
Hi, Angela. Thank you very much. ありがとうございます。Can you see my screen? Can you see it?
Yes, we can see it.
Okay. Yeah, sorry, I will talk in Japanese. 皆さん、こんにちは。国です。今、GHIT と言いまして、グローバルヘルス技術振興基金というところで働いております。今日はですね、AMR という話、話題なんですけど、もう少しちょっと広くですね、感染症というもので、具体的に世界でどんなふうにパンデミックまたは感染症が広がっているのか、それに対してその中で AMR というのはどういう位置づけにあるのか、それに対してまた国際機関がどんな努力をしているのか、その中で研究開発というのはどういう重要性を持っているのか、そういったことをお話をしたいと思います。はい。そうですね。まずはですね、1980年代、90年代のエイズのパンデミックっていうのがありました。これは実はコロナよりも当時、本当に怖がられていまして、というのも死亡率がほぼ 100% だったんですね。致命率ですね。患者さんが出ると、もうほとんどその人は治療もできずに亡くなっていた。ですから、コロナで3% 以下の致命率だと思うんですけども、それがエイズではほぼ 100% ということでした。で、また、この感染率がですね、非常に高くて、私もアフリカで働いてたんですけども、例えばザンビアという国に行くと 30%。3人に1人は HIV でしたし、南アフリカの地域に行くともうほぼ半分というところもありました。これによって、HIV は本当にもうアフリカなんかで広がり、この右側の写真はですね、マラウイというちっちゃな国なんですけども、HIV が流行ったために、それで働き盛りのご両親が亡くなって、で子どもたちが70万人も孤児になるというような時期がありました。この HIV とともに広がったのが結核です。重感染を起こして、主に結核で亡くなる人が非常に増えたんですね。これでも非常に結核が広がり、その死亡率がまた上がっていったと。またマラリアという病気もですね、実を言うと年間2億人も感染してるんですね。コロナよりも実は多いぐらいなんですね。毎年2億人以上ですから。またそれが最近の地球の温暖化によってまたそれが広がっていると。で、ここにプーチンもいるんですけども、実は2000年に九州沖縄で G8 のサミットありました。その当時は G8 でロシアも入ったんですが、その後ロシアが抜けて G7 になりました。この中にクリントンもいますし、いろいろいるんですけども、この時にですね、あまりにもその2000年 の時に、エイズ、結核、マラリアなどが世界で流行っていたので、そのパンデミックを起こしていたので、何とかしなくちゃいけないということで、GHIT で初めてですね、保健医療課題、特に感染症をどうにかしないといけないということで、みんなで力を合わせようということで、議論をし、その後、私が以前、9年間働いていたグローバルファンドなどができました。でかなりいい線いってたんです。2000年にこの G8 のサミットがあり、2002年にグローバルファンドができ、その後世界中にですね、この感染症の対策が広がったんですが、最近になってこの結核の多剤耐性結核、いわゆる結核の治療薬が効かないという結核が非常に増えてですね、特にロシア、この黒いところはロシアなんですけども、あとは実は今のウクライナ、あとベラルーシ、この3つの国がですね、実を言うと結核、多剤耐性結核が非常に増えておりまして、で多いところですともう本当に、患者さんが出たときにその3分の1以上が時にはですね、半分ぐらいが結核、多剤、結核菌が薬が効かない薬剤耐性の結核です。で、この問題はですね、実は多剤耐性の場合、治療薬があまり効かないものですから、昔はですね、入院を長くして、で、またいろんな薬を使って、高い薬も使って、で、また手術も必要だったんですね。で、アメリカなんかで昔はですね、薬剤耐性結核になると、3000万円から5000万円かかったんです。今、日本でもおそらく200万円ぐらいかかるぐらいに非常に高い。それが途上国なんかでは、本当にお金がない人たちが多いですから、結核にかかって、それが耐性菌の場合は、もう8割の人たちが本当にもうお金が払えない、貧困の罠になって、もっともっと貧困になっていくということになっていました。またマラリアもですね、最近アルテミシニンっていう薬が効かなくなったり、または殺虫剤が効かなくなってですね、で最近増えている国、いわゆる結核が、ごめんなさい、マラリアのケースが増えている国も多くなっています。西大西洋地域ではですね、アルテミシニンというとてもいい薬があったんですが、それの耐性菌もできて、これが最近ではアフリカでも増えているという話になっています。で、殺虫剤が効かないために、昔はとてもいい殺虫剤を染み込ませた蚊帳を使うと、子どもの死亡率が半分ぐらいに減ったんですね、マラリアの死亡が。それが最近効かなくなってきたということがあります。そのためにですね、特に結核は薬剤耐性が出ながら、この60年間、新しい薬が出てなかったんですね。で、また、ワクチンに関しては昔の BCG しかなくてですね、100年前のワクチンを使っているというようなことで、こういった研究開発をしなくてはいけないんですが、研究開発というのはとても難しくてですね、どこから例えるかによるんですけども、もうサクセスレート、10の研究があっても、1ぐらいしか成功しないというようなこともあります。また最近特にマラリアなんていうのは先進国であまり昔は日本にもあったんですけども先進国にはないので、マラリアの薬を開発しようというインセンティブが働かないんですね。結核もですね、このように実を言うと日本も中まん延国であって実は結構結核が多いんですよ。ところがその辺が知られないために、どうせ薬作っても開発費をかけてもあまり売れないということでほとんど先進国の製薬会社は作らないんですね。そのために100の薬ができても、こういった感染症、特に熱帯病の薬というのは100のうち1ぐらいしかないというような状況です。そのために作られたのが10年前に作られたのが GHIT という、これは日本では珍しいんですが日本初の官民連携パートナーシップで日本の厚労省、外務省がお金を出し、また UNDP なんかが絡み、あと日本のアステラス、中外、エーザイ、第三共、塩野義、武田などがやはりお金を出してですね、である官民連携です。これに加えて、GHIT ファンデーション、そして Wellcome Trust というとても世界では大きな財団も入っています。GHIT というのはですね、私もグローバルファンドで 一緒にいろんなことをやったんですけども、ゲイツのお金というのは非常に多くてですね、日本よりも実はゲイツの方がグローバルヘルスにお金を出しています。で、彼らは単にお金を使って現場に薬を送ろうとかそういう意味でなくて、世界の動向を見ながら、触媒作用っていうのなんですね。どこにお金を出していったらどんなふうにうまく動かせるかということで、ゲイツはWHO やグローバルファンドなどの大手の国際機関にもお金を出して、おそらくゲイツがお金を出さなくなると、今 WHO のプログラム、やっていけないプログラムはいくつもあるというぐらいになっています。で、この GHIT は私が今代表を務めているところは、ニグレクテッドディジーズと言いながらですね、全部で、結核とマラリアも含めてなんですが、世界で20億人が感染し、また200万人が死亡しているところです。これに対して、日本のイノベーション、テクノロジーを使っていこうということでやっています。世界160以上のパートナー、特に日本よりもですね、世界のパートナーが多いんですけども、ここで35カ国以上でやっています。今、多くのものがかなり出てきていまして、進めています。しかしですね、これに比べてコロナに関する研究開発はすごいですね。もう我々がやっている、何十倍以上のお金が今出てきまして、たった半年間で9000億円以上、1兆円以上ですね、1兆円以上のお金がこのコロナにという一つの病気につぎ込まれました。その結果、1年以内にワクチンができ、今現在でですね、ご承知のようにもう40ぐらいのワクチンが出て、まだ研究開発途中で、候補となっているワクチンがなんと200もあると。たった一つのコロナという病気に対してこれだけのワクチンができたと。今まで我々は研究開発に特にワクチンなんていうのはですね、十何年お金をつけてもなかなかできなかったんですけども、本気でやれば、本気でお金と専門家の力、努力をやればできるんだなということが分かりました。これ最後のスライドですけども、とにかくAMR っていうのは皆さんがお話ししたように、とにかく薬の開発以上に早く進んでるんですね。ですから、そういった意味では研究開発もきちんとしながらも、プリベンション、ミチゲーションのための先ほど言われたような医療の質であるとか、教育であるとか、いろんなことをしなくてはいけない。で、これに対して、先ほどアナンも言ってましたけれども、やはり、総合的、またクロスカッティングな対策をしないといけないので、AMR だけでなく、またパンデミック対策だけでなく、すべての感染症をきちんと平時からですね、総合的な対策をして、計画をして、それを世界のいろんなパートナーと一緒にやっていくということが必要だと思います。また日本の政府、そして NGO、アカデミア、プライベートセクターは、お金だけでなく人材もですね、どんどん世界につぎ込んで、日本国内だけでなくて世界的に活躍してもらい、その日本のテクノロジーとかプロダクトを国際的貢献をしてもらいたいと思っています。以上です。ありがとうございました。
Thank you so much, Dr. Samu. That was very interesting. And I think it highlights again the relevance that it has to work within the sectors and between the sectors, academia, private sector, and public sector to fight antimicrobial resistance. You touched on so many different important aspects, the imbalance on funding, the relevance and the transversality that antimicrobial resistance has. You mentioned human resources for health. You mentioned R&D. You mentioned things that are transversal to our health system. And taking on this, I would like to invite the people, please attending, to have, if you have any questions, please put it in the chat. We will go now to some of the questions. So please, all the panelists, switch on your cameras. I will have some questions here, and I will like probably to start with, I will go back to Dr. Samu briefly to ask you, what do you think once the drugs and the products are developed, if it happens hopefully soon, what are the other challenges we will have to access these drugs and these diagnostics once they are developed? Like from the population perspective, from the government perspective, what do you think are other challenges we need to tackle? Pricing issues, supply issues, I don't know. Please.
ありがとうございます、アンジェラ。 it is very important issue. とても大切なお話ですね。とにかくですね、エイズの薬が開発された後、アフリカで広がるのに、そのタイムラグがですね、7年から9年ぐらいあったんですね。なぜかというと、まずはプライスです。金額がやはり高いんですね。研究開発には相当なお金かかるんで、それでやっぱプライスがなかなか安くならない。プライスイッシュ。もう一つやっぱりですね、プロキュアメントとサプライ、ロジスティクスと言いまして、もう現場でそれを広げるのは大変なんですね。私はアフリカとかミャンマーとか、ケニア、あとブラジルなんかで働いたんですけど、もう田舎に行くと本当に果てしない田舎なんですね。もう道路もない。で、船でもう何日も行かなくちゃいけないっていうところがありまして、ラストワンマイル、最後の最後の本当に必要な患者さんのところに持っていくのは大変なんです。ですから、このサプライロジスティクスっていうのをきちんとしないといけないんですね。で、薬は大体大丈夫なんですけども、中にはやっぱり高い、アフリカの暑いところですぐにダメになってしまう薬とかもありますので、それを温度を調整しながら、どうやってもう最後の最後まで送るか。で、送った後ですね、今度は人々が飲まないっていうこともあるんですよね。それが苦いとか、上手が大きいとか、あとはそれをなかなかストック、アウトと言いまして、診療所に行ってもないとかですね。ですから患者さんとか人々への教育も大切なんで、先ほどアナが言ってましたけども、やはりピーパーセンター、どうやって本当に必要な人のところに届けるか、その全ての工程を見て、そのボトルネックを一つ一つ解消しないといけないっていうのがあります。でもできないことはないんで、それを一つ一つやっていくということですね。はい。
Thank you so much, Dr. Hossam, for this comprehensive answer. Yeah, indeed, there are several challenges, and this is why I'll jump back to Mr. Anand, because you mentioned the link with health system strengthening, and I think we discussed this before, and how important it is to tackle different aspects. But now we see that there is a global agenda putting a super focus, an extra focus on the pandemic preparedness plan. And I wanted to ask you, where do you see the intersections? How we can, the advocates for AMR, set the agenda there? Where do you see the opportunities, please? Thank you.
That's a very good question. Thank you for that, Angela. In fact, the World Health Assembly is starting, and this is one of the critical issues being discussed, which is the pandemic preparedness, almost like a treaty that they're going to develop. And many countries have already raised the issue that AMR needs to be included in the pandemic preparedness treaty. And also any financing mechanisms that will be aligned with it. So for example, the Global Fund is now having pandemic preparedness as one of their pillars to support countries, not just focus on HIV, TB, and malaria, but pandemic preparedness. So here we have provided inputs, and we are advocating that based on our health systems approach, there needs to be a focus on, first, in terms of education and training for the critical, healthcare providers, but also for the community. Secondly, the prevention aspects need to be really strengthened. So how can they further include IPC and WASH as a very critical element that needs to be strengthened? Thirdly, access to diagnostics. The Global Action Plan on AMR completely missed this issue of diagnostics, access to diagnostics, and strengthening bacteriology lab capacities in low and middle income countries. This is a major problem. If you don't have access to diagnostics, then you're going to get whatever the doctor, plans and says, okay, by just looking at a patient, they will just prescribe something. But this can cause significant problems in the long run. So we are pushing that the whole issue of access to diagnostic capacity and the supply chain, so that these labs will be functioning in these countries where in many situations they don't even have water and electricity in the primary healthcare centers. So that is a critical issue. And lastly, we are pushing that the issue of access to what we call access antibiotics be strengthened. WHO has come up with a classification called the AWARE classification of antibiotics. So you have access drugs, you have watch drugs, and you have reserve drugs. Sadly, in many low-income countries, especially big countries like India with huge populations, even the watch level drugs are being very freely distributed. So we are, as Dr. Osamu Kuni said, we are facing a situation where resistance is growing, but there are no new drugs, and the private sector does not have the incentive also to create new drugs, new antibiotics or antimicrobials. So we are facing a critical challenge. And one way we think the challenge could be addressed is in the prevention side. So by engaging the community, increasing prevention in terms of IPC, WASH, and even immunization, many infectious diseases can be prevented by increasing immunization rates. So we need to also focus on that, and then increasing access to these things. So we are pushing that pandemic preparedness and the global health security agenda continue to include AMR, but look at AMR from this health system perspective, and not just surveillance of the pathogens and then producing antibiotics. But we need this people-centered approach, and we need the community to be more aware. So I was very happy to see in Gaza some of the many elements that you pointed out. It resonated so well to me in terms of awareness, education, IPC, and the good treatment protocols, treatment guidelines. So I was very impressed by the presentation from MSF Gaza. Thank you.
Thank you so much. And indeed, I think we have several priorities and several aspects needs to be tackled at the same time. And the intersectoriality is still one of the major challenges. I think one of the key issues is how do we prioritize? Because I think everyone puts their agenda and hooks it into the health system strengthening approach. So we will have to compete with others, but I think that the essential parts in human resources for health, access to basic and essential drugs, and access to microbiology are key issues where we can already focus and align with all the agencies and topics. So talking about the pandemic, I would like to go to Dr. Hiroshi to tell us more, because I think COVID has had a huge detrimental impact on antimicrobial resistance. How do you see this in Japan, and what has been the impact of the pandemic? Please, Dr. Hiroshi.
はい、日本において COVID-19 がいろいろあった非常に広がったわけですけども、実は日本においてはある意味逆の現象も生じていて、つまり診断自体が COVID-19 か COVID-19 じゃないかっていうふうな2つに実は分かれました。で、COVID-19 ではないとなると、結局それは抗菌薬を出そうというふうなことを医者が実はあまり考えなかったっていうふうなことが逆にあったんですね。ですので、世界でも同じようなこと言われていると思うんですけども、COVID-19 自体は、抗菌薬の処方自体は、重症のところは別です。ICU みたいなところに行くと必ず抗菌薬を使いますから、そういった肺炎を起こしているような症例に関しては、大きな問題が生じましたけども、一般の多くの人に対しては、日本においては、そういった問題が生じなかったということがあると思います。あとはグローバルな視点で言うならば、アフリカなんかは例えば本当に人口の半分以上がもしかしたらば COVID-19 にかかってしまっているかもしれないということがあると思うんですけども、そうすると先ほどアナン先生が言われたような診断にももちろん全然届かない。そして治療も全然届かない。ましてや何かAMR があっても抗菌薬も投与されないというふうなことで、実はそういったような AMR 自体は今まではあまり大きな問題になってなかった。ただこれから我々はCOVID-19 の先ほど国井先生がおっしゃったように、たくさんのお金を使ったりして治療薬にしても予防薬にしても手を入れた。そうするとこれから先は他の感染症、バクテリアルインフェクションがどんなような状態にあるかというふうなことにやっぱり医療従事者も含めた皆の目が行く。 で、AMR 自体は、先ほどアンナン先生がお話をしたように、年間500万人の人がやっぱり亡くなる非常に大きな問題で、しかも実は、一番最初にランセットの論文出されてましたけど、最もたくさんの人が亡くなっているのはアフリカです。特に西アフリカです。で、これは何で亡くなっているのかっていうと、肺炎で実は亡くなっている。で、肺炎でそのきちっとした抗菌薬が届かないで亡くなっているというふうなところで、実は抗菌薬自体が届いていないという問題もありますから、それも問題になる。それから、さっきさんのホッサム先生がおっしゃったように、実はそのガザ地区っていうのは、MRSA の感染症が非常に多い。これは当たり前で、骨髄炎に対して一番その一番の原因はやっぱりブドウ球菌なんですね。で、ブドウ球菌という菌っていうのはやはり他の菌に比べると非常にやはり病原性、毒性が高くて、非常にその重篤になる。そして骨髄炎という病気っていうのは実は治療するのに非常に長いこと抗菌薬の治療が必要である。ただ、おそらくその入院なんかも、例えば日本でいうならば2週間ぐらい、最低でも入院をして、あとはなんとかその経口の薬に持っていって退院に持っていったりするわけですけども、それでも1ヶ月以上のやっぱり抗生物質の投与必要なんですね。で、そういったことをやることができるようになるのには、やはりすごい長い期間がいる。で、抗生物質がちゃんと使えないと、当然その耐性菌による感染症が大きくなっていくということで、今はグローバルの視野、ちょっと質問の趣旨から出てしまいましたけども、そういったような幾多の問題点が実は最終的に AMR につながってしまっているというふうなことを申し上げたいというふうに思いました。以上です。
Thank you so much, Doctor. And I think we all highlighted and praised Dr. Hossam's presentation. And I think what we see in Gaza, it's because Gaza, we in MSF, we have several projects around the world where we implemented the plans for antimicrobial resistance, but we are seeing like some extra challenges in conflict-affected areas. And again, not only because of the conflict per se, but also because of the wounds, the kind of wounds that these patients have. So places like Gaza have a specific layers of complications and complexity of this problem. And I would like, because we are running, of course, assessments to see the access barriers and the challenges in these countries, but it's very interesting what I'm finding in Palestine and specifically in Gaza. Dr. Hossam, can you tell us a bit about what are the challenges today for action against antimicrobial resistance from the healthcare perspective? Thank you.
Yes, actually implementing the antibiotic stewardship program was a successful implementation for MSF, but it was in very restricted area, which is the area of osteomyelitis, which it not reached the public. So it's a public problem, not restricted to those injuries and not restricted to only people with osteomyelitis. The challenges we faced with osteomyelitis cases, like Dr. Hiroshi said, the osteomyelitis cases are very difficult to treat. Usually in our protocol, in the MSF protocol, we need to give the intravenous antibiotic for at least 2 weeks. Then the oral treatment can be extended to 12 weeks. So it's a very long period of antibiotics that have many side effects and need a close follow-up, and it's very expensive also. In some patients we faced, we didn't, because of the bacterial resistance, we didn't find an oral option for the patient. So the patient need to stay in the inpatient department in the hospital for 12 weeks to receive the antibiotics. And also the outcome is not guaranteed. It's not guaranteed that you will cure this infection despite giving all these antibiotics and all this hospitalization. So for the action plan, it is actually a big decision, need commitment from the decision makers here in Gaza. The decision makers need to be aware about the magnitude of the problem. and they need to raise the awareness about this issue. Actually, we have zero policies in the public, in the pharmacies, in the hospitals. There's no regulations at all. There's no protocols for prescribing antibiotic. In our governmental hospitals, we have no antibiotic stewardship programs. And adding to that, the absence of the required labs that needed to do the culture and sensitivity tests, and the shortage of equipment and treatments. All of these challenges need to be studied and need to be faced. Actually, the other issue that we face, that the pharmacological companies here, they distribute the antibiotics on the doctors as samples, as advertisement, to enhance them to prescribe antibiotics that make the medical staff and the doctors a big part of the problem. So awareness needs to be raised mainly among the medical staff and the doctors to prescribe antibiotics only when it's needed, and awareness needs to be raised among the public, because here the public awareness is whenever you had fever, whenever you had cough, whenever you had any issue, just buy antibiotic, go to the nearest pharmacy and buy antibiotic. So awareness among the public need to be raised. These areas are the most important areas to work on. Adding to that, the surveillance and research area. Actually, before MSF, no one know about this problem. No one do research or surveillance about microbial resistance. So we have here medical schools. We have 2 medical schools. We have also public health schools. They do research regularly, but no one do research about the microbial resistance. So these schools need to be aware of the problem and need to increase research in this area to know the magnitude and the effect of this problem on an area like Gaza.
Thank you so much, Dr. Hossam. I think you gave a very comprehensive picture of the issue. And also something I see, particularly from my perspective, is the difficulties on funding a place like Gaza because of all the issues, and also the lack of actors focusing on AMR. I mean, I think we need to call more civil society and different organizations to participate. And I think you, Dr. Hiroshi and Dr. Hossam mentioned different ways that we can tackle platforms as the G7, as different actors as the Global Fund, like the Global Fund and others. I think we need to use all our tools, the advocates for antimicrobial resistance, to send the message and to put it back, because the challenge is, again, it's an invisible problem. And despite the fact that the Lancet report was fantastic, let's not forget that in many of the cases, this is produced by sentinel sites specific for specific pathogens. So we really do not have yet the overview we would like to have on the burden. So, and I have a bit of a concern about some neglected resistances that we might have, because the focus right now on the antimicrobial resistance is very much on carbapenem resistance. And I think there might be other resistances, like we see strains of cholera resistance, we still have to deal with the tuberculosis resistance, with malaria resistances, and others that are falling out of the table. I don't know if any of you have any comment about this neglect of some resistances.
I could just add to that, Angela. the Lancet study did give us an estimate of the different pathogens that have an impact. So we are aware, at least based on their modeling, as to the impact of various bacterial infections. But we know that resistance to first-line malaria drugs is increasing. For gonorrhea, this should be a global emergency, because even the second-line drugs are not working. It's a really major problem. We are seeing Shigella now spreading. In fact, it's an outbreak, drug-resistant Shigella. So there are many other things happening, and the GLASS system has created now an outbreak, emerging pathogens, to track these emerging pathogens. Also, I should add fungal. Antifungal resistance is also something that is not well captured, particularly when it's used herbicides, pesticides with antifungal properties are sprayed in crops and used by farmers. A lot of them are getting drug-resistant infections in their lungs. And coupled with COVID, it is creating havoc. This is not really being discussed as well. So the antifungals is something we are expecting to see as a big problem in the next 5 years. Yeah. So you are right. There are many other. This is a much bigger problem than just bacterial resistance. But we need to focus on what's having the biggest burden at this point. Yeah.
Yeah. Thank you so much, Dr. Kuni.
はい、アンジェラありがとうございます。neglected disease というふうに病気も大切ですが、neglected people の方が僕はもっと重要かなと思ってます。つまり多くのそういう AMR で、治らない人々、またはそれがどんどん起こる理由として、いい病院にかかれないような人がいたり、または例えばゴノリアの話言いましたけども、若い10代の子どもたちが、いわゆるセクシュアルで広がって、ところがやっぱり病院に行ったりするのが嫌だからって言って、近くの薬局とかで、特に途上国なんていうのは普通に薬局でアンティバイオティクス売ってますので、もう普通にプレスクリプションされちゃうんですね。でそういうのを結構飲んでしまって、で耐性菌を作ったりということがあるので、どこにきちんとそのサービスが、適切なサービスが受けられていない人々がいるのか、それをきちんと見つけていくっていうことも重要なのかなと思うんですね。私グローバルファンドで仕事をしていた時に、とにかくエイズも結核もマラリアも結局そういう neglected people、 またはいわゆる差別とか偏見とかいろんなものがあったり、また社会の変縁にやられるマージナライズポピュレーション、そういった人たちの中で流行ってそれが広がっていくっていうのがあるものですから、やはりこの AMR についても、病気も大切なんですが、やはりネグレクトされた人々、どこにそういう人たちがいるのかっていうのをきちんと見つけながら、そこにアウトリーチしていくっていうのが大切だと思います。
Thank you so much. And briefly, Dr. Yotsuyanagi, please.
はい、先ほど最初の時にCOVID に対するご質問がありました。で、COVID やっぱり一番印象的だったのは、ものすごいスピードでワクチンが実はできて、で、メッセンジャー RNA のワクチンが非常に効果的だったということだと思います。で、実は、そういったことは、欧米の製薬会社を含めて、実はグローバルに提供しようということでお金もかけている。で、理屈から言うと、メッセンジャー RNA のワクチンというのは実はいろんな病原体に対して使い得る。アナン先生もおっしゃいましたし、国先生もおっしゃいましたけども、実はワクチネーションによる予防、そして、IPC というふうなことによる感染制御っていうことは、実はその感染症の頭叩きをすることよりも将来的には大事で、そのためにはそういったワクチンを作ったものをどのようにグローバルにやっぱり配布をするか、そしてそれを結局投与するときに衝撃になるであろうというふうな教育に対するですね、そういった無知をどうするかというふうなことを、おそらくそういったことを治療のAMR に対する治療と並行してやっぱりやっていくことが非常に私は大事だというふうに思っています。
Thank you so much, Dr. Hiroshi. And unfortunately, we need to wrap up and close, but Just to say, it was really a pleasure to exchange so many thoughts about antimicrobial resistance from different perspectives. We started with Mr. Anand summarizing very well the global situation. And despite the great advances, we still see limited collective action on the One Health initiatives. You also highlighted the relevance on the information we need in key aspects such as importation of antibiotics. It's macro data that is necessary to understand what is happening. Thank you for highlighting the lack of access to diagnostics and antibiotics, which I think is a key area for humanitarian medical actors such as MSF. Thank you, Dr. Hossam. You illustrated very well some of the issues we see in the field from the MSF perspective, where war-wounded patients are greatly affected by antimicrobial resistance, and the impact in Gaza has been completely detrimental. And it goes beyond the war injuries. Some of these people really suffer these injuries that are very painful and very difficult to treat. So I think this is a key aspect for humanitarian actors such as MSF on our speaking out and témoignage role. Thank you so much, Dr. Yotsuyanagi. You told us more about the Japanese governmental policy and the strategy on AMR. You highlighted some of the key activities developed by the AMR Alliance and how working with different sector matters, such as academia, the private sector, and the public sector. Some of the recommendations from the AMR Alliance point on the direction of education, R&D, supply, and others, which are really key and need intersectorial action. I like the way you highlighted the influence that we can have on the G7, because I think it's a fantastic opportunities for global health advocates. Thank you so much as well, Dr. Hossam M, because you told us a bit, you remind us a bit on the history behind global health and the resistances, and you remind us some of the greater channels for funding, such as the Global Fund and the action they can have. You touched also on resistances such as MDR and malaria, which are not always mentioned in this kind of forums, that are still pending homework that we have to do. I think it's important also to talk about the imbalance in terms of funding. Where is the funding? And it should be directed to the key areas that several issues share in common. So I would like to thank to the organizers, to MSF Japan, specifically to Sarah and others who have been very helpful on organizing this event. And thank you for the people who attended and sent their questions. So we close this session, and thank you so much to all the panelists. Thank you. Have a great day.
Thank you very much.
Thank you. Bye, everyone.
Thanks for the invitation.
Bye.
Thank you.